Good afternoon, everyone. My name is Nirupama Yechoor. I'm an instructor of neurology in the Division of Neurocritical Care at MGH and Harvard Medical School, and I'm also one of the investigators at the McCants Center for Brain Health. I just want to take a minute and thank Drs. Asher Albertson and Teresa Human for the invitation for this talk, and thank you to you all for your attention today as well. I have no disclosures to state. So I consider it the most enormous privilege of my life to be a physician and care for people in their time of need. I consider myself first and foremost a clinical doctor. However, the impact that we have not only on the patient sitting in front of us, but for all the patients that walk through our door is the direct practice of public health. Therefore, I see all of us as public health researchers. And one of the driving principles of public health is health equity. Although I and many of you likely in this audience have been born in, worked in other countries, and traveled to other countries, I think sometimes the most salient examples of health inequity lie in our own backyards, in our very own institutions. When I was an ICU fellow, I wanted to share a case from that period of time. I was working with the wonderful Dr. Brian Edlow, who's taught me everything I know about coma recovery. This case highlights some of the challenges that sort of affect our decision-making in coma recovery. And I just want to take a minute to praise Dr. Edlow. He really was an example of somebody who championed health equity and equitable care. The case was a 25-year-old female who was admitted to an outside hospital with a very rare form of an adult T-cell leukemia. Her course was complicated by very high fevers, over 41 degrees for several hours, HLH, and multipressor shock. She was transferred to MGH for neuroprognostication, but Brian Edlow advocated for her to do that, and to actually have her come to the hospital was an enormous task. He navigated working with hospital administrators, clinical staff, and the patient's family. When she got to MGH, we were able to provide her family with key information using task-based fMRI and EEG. Her family was very torn on making the decisions around goals of care for this patient, given how young she was, her exam, as well as her history. I'll get back to you at the end about what happened with this young patient, but it was just a really big, memorable case for me because it highlighted how much of a champion we as physicians have to be for equitable care, especially in coma recovery. Before I go into equity, I wanted to give you some examples of health disparities in coma research that have already been done and that are excellent cases. This first example comes from the New York Neurotrauma Consortium. And what they did was they leveraged their diverse population in New York to understand the barriers that face their population in coma research. They compared what the barriers they found were to low and middle income countries around the world where TBI and road traffic accidents make coma very prevalent. They found several examples and similarities that not only occur at the health system, but in pre-hospital care, as well as in challenges in post-TBI recovery and rehabilitation. Similarly, in the stroke literature, Dr. Burke and his colleagues looked at inequitable care for their Black patients. They found that Black patients actually present with lower mortality, but end up having a greater disability. They found that their Black patients, compared to their counterparts, not only receive treatment for ischemic stroke less often, but they also had higher incidence of life-prolonging procedures, including tracheostomy, as well as gastrostomies. So what are all these examples of? I'm sure the cases I've described and many that you've experienced kind of trigger the similar memories. And so I ask that we all pause and understand that even sometimes with our best intentions, what we really represent in our practice is a theory of equality when we should be striving for equity. Health equity is attainment of the highest level of health for all people. The above two graphics are worth taking a moment to reflect upon. The first one comes from the Interaction Institute for Social Change and was published in 2016. And the second one comes from the Robert Wood Foundation Institute, was recently published in 2022. They both kind of exemplify that when we take a one-size-fits-all approach to our patients, nobody really wins. Therefore, I argue that health equity is a form of personalized and precision medicine. There's the same graphic that comes from the Interaction Institute of Social Change, but I think represents our reality a little bit more clearly. It begs the question, what is the role of us as physicians? In my experience, what I've seen is that we're just okay at kind of describing the barriers and challenges that our patients face, but we're much less equipped to actually practice with the lens of health equity to really help our patients and make social change. So if you're like me and you're wondering, does this seem too big to tackle? What are the next steps? What are the next steps? I encourage you and want to reassure you that there's some really smart people thinking of solutions. In fact, a Toronto physician just published a fantastic article in January 2023 as part of the Kenton Stroke Lecture on Health Disparities. Dr. Kepral gives us an excellent framework for how to sort of deal with health inequity in our patient populations. She first asks us to understand why these inequities exist and then go beyond just descriptions. She actually challenges us to think about topics that are not frequently discussed in medicine, including the role of structural racism, as well as intersectionality. Finally, she encourages us to learn from the existing research and really work towards dismantling disparities. Even with this excellent framework, some of us may be wondering where to sort of go from here. And where I challenge you is to think about one thing that Dr. Kepral writes about is involving our affected communities. If you start by involving your own communities in research, this is a concrete, feasible, and an excellent place to start. Partnering with patients to learn about their experiences with the health system can be applied to any clinical setting, whether in the ICU, in rehab, or even in the outpatient setting. This sets the stage to build ways for shared decision-making. Think about how important this could have been for all of the cases that I presented at the beginning of this talk. Partnering with an individual, a focus group, or a community can all lead to concrete solutions to reducing health disparities, especially in Coma research, when we are dealing with really important decisions around life and unfortunately death. These are all very socially and culturally specific philosophies. And when physicians show an attempt to understand some of these philosophies, it can go a long way in promoting equity in care. So if your institution is way ahead of me and you're thinking, well, we already use advisory boards and we partner with our patients to learn about their experiences, and you're asking, what is the next step? Well, I challenge you to think about choosing an existing framework to help navigate and adapt health equity research. We have these frameworks that we use for population sciences, genetic sciences, as well as public health research in all of our institutions. The one that I've been really drawn to comes from the U.S. Department of Health and Human Services called the Healthy People 2030. I really like this framework because it's up to date, it's patient-facing, and it's easy to understand. They also have one especially dedicated to health equity. One of the best examples why I think that Healthy People is a great framework is that it stays up to date with the field of public health. I'd like to give you guys my favorite example. Health literacy is a frequently used term in health equity research. However, in 2015, the pioneer of health literacy, Dr. Rima Rudd of the Chan School of Public Health here at Harvard, urged us to think differently. However, as frequently is the case, this hasn't really been adopted into our practice yet. She describes this in this article that I've put up here on this graphic. An older idea is that we should be assessing personal health literacy or understanding the individual's health literacy. But with our patients who are in a coma, that doesn't really make sense or apply. Instead, what we really is the key next step is to look at organizational health literacy. I've placed this definition above, but we as an organization should be asking ourselves, do we deliver education to our patients that's accessible, understandable, and actionable? I challenge you to think about all of your institutions and think about how you deliver information on what coma recovery is and ask, does it make sense for every patient population that you've had to deal with? So when I think about the times where I've witnessed some of the greatest health inequities in clinical care, I also remember feeling the most impassioned. I want to go back to the case that I presented at the very beginning of this talk. Dr. Edlow advocated for this patient and her family so strongly and passionately. He got her to MGH. We were able to do the testing and provided some really needed information to the family to help them make some goals of care decisions. But we didn't just do that. We also reestablished trust with them and the medical system. And they said to us very honestly that they felt relieved to know this information. And so he was really a true champion for me that day, and I won't forget that case. I hope I made the case to you that we must do better as physicians and given you a small toolkit on how to start. If you find yourself way ahead of me, please feel free to reach out and share your experiences. I hope you also understand that there are a lot of frameworks out there, and choosing one that works for you might be the best way to start providing health equity research in your institution. Thank you all so much for your time and attention today. I also want to take the time to thank my mentors, Dr. Jonathan Rosen, Dr. Anderson, Dr. Rosenfeld, and Dr. Rist, and thank all of the members of my lab. Thank you again for your time.